And then when the patient says her leg hurts, that by default tells me that the patient is breathing, is able to talk to you. If a patient is able to breathe, if a patient is able to talk to you, you know they're breathing, you know they'll be able to respond, and she's responding actually appropriately because her leg is hurting. So in the actions that I want to do, I want to address the driver's issues first because he's not breathing. I have to do something. So first thing I want to do for the driver is I want to manipulate his head and his airway, kind of open it up. Maybe his head's in a irregular position. Maybe his airway's kinking up a little bit. So we do maybe like a jaw thrust action. I mean, kind of lift the jaw up a little bit, kind of open it up a little bit, or just kind of manipulate your head a little bit. So we open up the airway. That may help. If that doesn't work, we go intubate the patient. I'm sure you're all familiar with this, and I'll show you a slide a little bit with this. And then, like I mentioned earlier about the passenger, she said her legs hurt. I wouldn't do anything right now, but I'll come back to her. So the first course of action I want to do is intubate this patient. In intubation, this is a process of putting what we call an endotracheal tube, putting a tube into someone's trachea into their airway to help them breathe. I'm sure you've seen this all from TV and it's become very popularized right now. But briefly, it implies of paralyzing the patient and sedating this patient and putting an ET tube, endotracheal tube, into the airway and securing it and blowing it up. By doing this, you're actually taking someone's life in your own hand. In order to get this ET tube down, you have to paralyze and sedate them. You just think about it. If you just pretend like you're drinking your like soda, you kind of accidentally push a straw in the back of your throat. You gag a little bit. So this is the same thing, but the ET tube's a much bigger straw. It's like the size of your thumb in terms of the diameter of it. So you're pushing a big tube down to someone's lung to help them breathe. So when you intubate somebody, you're actually controlling their life, and you have to be very respectful of that. And once you intubate them, then you have to put them on a respirator, on a ventilator. So in this case, the driver is intubated, and we maintain his airway. So that's secure. So what do you do next? So you go back to and do your history and physical. You go back to the driver and you kind of look at him. There's no visible signs of bleeding with him, at least first glance. You go back to the passenger and you look at her. And you notice that there's a bleeding from the from the left thigh. The pulses are weak and the limbs deformed. So what do you think is going on with the passenger right now? Yeah, something's broken. There's a big movement and something's broken. And when we say the limbs deformed, it's not coming down straight, it's kind of on the side crooked. So given what you know right now, what do you want to do? What do you think you want to do to this? In this case, for the driver, I won't do anything, right? Because I don't see anything that's really significant going on with him right now. But the passenger, it has a bunch of things going on, which I'm really worried about. Okay, first of all, you see bleeding from the left thigh. I didn't quantitate how much blood that the patient had, but if it's a lot, you have to do something about it. You want to put direct pressure on it, right? I mean, one of the things that we kind of like joke about in emergency medicine, but it has a lot of truth to it. Anything that's bleeding, put direct pressure on it. It seems kind of common. I mean, that's what you do out in the field if you do first aid, but that's what you do actually in the ER. That's the first course of action. The pulses are weak. That tells me something bad's happening. Meaning the vasculature, meaning the blood vessels, the artery, for some reason is maybe injured or something's impeding blood flow down to that limb. And I probably think something's impeding blood flow back to that limb because the limb's deformed. So if the leg's angulated or somewhat deformed, what you want to do is kind of bring it back into a better position. So what you want to do is place a splint on it. Okay, direct pressure. Pretty obvious. I mean, if you learn any type of first aid, that's what the first thing you want to do. You do first aid, direct pressure. But in terms of a splint, this is one of the splints here we use in the ER. Also, EMS uses it as well. This contraption pretty much wraps around your ankle, and the other end. See, this particular end is kind of abutted against the top part of your thigh, and what it does is it pulls the leg into what we call traction. So if the leg was deformed, we want to kind of pull it back into length, try to reduce where the area of that deformity is going back to more in line with it was normally what your leg should look like. And hopefully, when that is done, the blood vessel won't be kinked or have pressure upon it. And at that point, you hope that the blood flow down to the distal part of your leg, meaning the part of your leg down the toes, you are able to sustain perfusion at that point. So we do this, we put direct pressure, we put the splint on, the blood pressure improves. So what I've done with this little scenario here, I've taught you about the ABCs of emergency medicine, right? So this is like one of the big things about emergency medicine. We always talk about the ABCs all the time, right? ABCs 1, 2, 3, right? For us, the ABC is airway, breathing, circulation. I'm kind of taking you through this case example of what's important to us. You know, airway, breathing. With the driver, in this particular case, the driver wasn't breathing, and he was breathing at a really, really slow respiratory rate. I think at 4. Right, so that was the most immediate life-threatening event that we identified, and we controlled it by intubating this patient and putting her on a ventilator. The next thing in our algorithm of care is circulation. With both of these patients, this lady, the passenger, had issue with the circulation because we felt weak pulses and the blood pressure wasn't normal. We wanted to stop the bleeding and put the leg into length to get perfusion down to the patient's leg. So if there's a primary survey, the secondary survey is kind of everything else, meaning we kind of examine the patient from head to toe, from front to back, and got identified any other injuries. The reason why emergency medicine docs think like this is we want to address the life-threatening events first. All right? It's kind of easy to get really, I guess, taken aback by looking, oh my goodness, you know, there's an injury down to the toe. Oh, there's an injury to the patient's tooth. But those are not like really things that we concentrate first when someone comes in traumatized. We want to make sure things with the heart, lung, and brain are safe first before letting the tooth or the fingers. It seems very intuitive, but when you get caught in the moment, sometimes kind of forget what your priorities are. So secondary survey, pretty much you kind of go through everything else, meaning you get more history, find out what else other things are going on, find out what the past moments. You see this patient is hypertensive, has a history of diabetes, what medications the patient takes. All these little things kind of add up, give you a better complete picture of what's going on. And obviously you do more complete exam. So we go through the secondary survey with our driver right now. So from a neurological exam, this patient is withdrawn from pain. He has pinpoint pupils and has bruises to his head. Normally, when you do your exam, when you're withdrawing to pain, that tells me something's going on with the patient's brain. He's not functioning, he's not pushing you away. Withdrawing is a very primitive action for a patient. Pinpoint pupils, if you kind of look at your pupils, right, it should be normal maybe about 4 to 5 millimeters in diameter. When we say pinpoint, it's about 1 millimeter in diameter. That tells me something bad's going on. There's some sort of brain injury going on when we examine. And bruises to the head, that kind of clues me, hey, something maybe is going on. So the action I want to give for this patient is, we already intubated this patient, right? We knew that the patient's airway and breathing was in control. But with my secondary survey, meaning you have pinpoint pupils, the bruises to the head, it tells me something's going on with the head. This patient has signs, clinical signs of a brain injury. So with any kind of brain injury, the brain, it fits within the skull. The skull is like a big box that doesn't expand. However, when the brain is injured, it wants to expand, it wants to swell. But if you try to expand something in a fixed space, something's going to happen, something's going to get squeezed. The only thing that's going to get squeezed is the brain, meaning the neuron cells. So what we want to do is reduce some of that edema, that swelling. And what we want to do is give the patient some mannitol. Mannitol is a medication which you want to get rid of some of the fluid. And hopefully when you get rid of some of the fluid in the body, you kind of reduce some of that swelling that's going on in the brain. But within the ER, we have to find out what's going on. We not only have to take care of patients, but we have to make a diagnosis of what's going on. So we have to act, which we do. We intubate, we gave mannitol, but then we have to find out what exactly is happening, what they need to do.